Welcome to B'madzaji Ginonindwa. This podcast is produced by the Communications Department at the Anishinaabe Nation. We will be focusing on the issues and initiatives in Anishinaabe Nation territory. I'm your host, Lisa Abel. The Anishinaabe Nation hosted its 10th annual health conference in October. Keynote themes of the conference included life after loss, Anishinaabe, policing in our communities, and elder abuse. Today's conversation is with Dr. Rennie Linklater, who presented a keynote at the conference on trauma and culturally informed care. Rennie Linklater, PhD, is currently the Senior Director of Shkaabe Makwa, a Center for First Nations, Inuit and Métis Wellness at CAMH, the Center for Addictions and Mental Health in Toronto. CAMH is Canada's largest mental health teaching hospital and research center. Shkaabe Makwa acknowledges that culture is central to healing and wellness. The center's name, which was received in ceremony, translates to Spirit Bear Helper in Anishinaabe. The center aims to transform health outcomes through the advancement of research, training, and innovative healing models that harmonize traditional knowledge and medical expertise. Shkaabe Makwa's clinical services provides outpatient groups and individual counseling to First Nations, Inuit, and Métis people experiencing substance abuse and mental health issues. Clinical services also support patients staying at CAMH. Shkaabe Makwa's workforce development program delivers culturally informed education and training to First Nations, Métis, and Inuit service providers across Ontario who work in mental health, justice, and education. Shkaabe Makwa also collaborates on Indigenous research and supports wider reconciliation at CAMH. Rennie Linklater has been involved with CAMH for many years. She is a member of Rainy River First Nations in northwestern Ontario. Her doctoral studies were completed with the Department of Adult Education and Counseling Psychology at the Ontario Institute for Studies in Education at the University of Toronto. Rennie has worked across the health and education sectors as a frontline worker, program evaluator, curriculum developer, and educator trainer. She is an international speaker on trauma and healing and is the author of Decolonizing Trauma Work, Indigenous Stories and Strategies. Dr. Rennie Linklater, Miigwech for joining us today on B'madzaji Ginonindwa. Welcome.
Miigwech, Lisa. Great to be here.
We're here today at the Anishinaabe Nation's annual health conference in Sault Ste. Marie. So I was pleased to attend your presentation you did on working in the context of First Nations health, trauma, and culturally informed care. So we presented that with the group yesterday. So tell me about your work at Shkaabe Makwa. What does the organization do?
Shkaabe Makwa is a center within the Center for Addiction and Mental Health, which is one of the 4 mental health hospitals in Ontario. And it's interesting because we have a number of different centers within CAMH, and some are strictly research-based, and some centers also include patient care. And so Shkaabe Makwa is a center that really aims to address issues around health justice. And so that's kind of the legal piece of when we think beyond just health equity. And so we have a real intent of, working with our communities and working with our people to better understand what do we need within the mental health system to be able to help people on their path to recovery. And so we are a hospital-based service, and we have areas in our work that work right across our hospital in terms of some of our strategic initiatives. And I would say that our hospital has changed a lot within these last years. And it's interesting because CAMH opened as a hospital in 1998, but it was actually the merger of 4 hospitals that came together. And our original hospital was opened in 1850 and was called the Provincial Asylum for Lunatics. That was later renamed as Queen Street Mental Health Center. And so it amalgamated with the Clark Institute for Psychiatry, Donwood Treatment Hospital, and the Addiction Research Foundation. And 2 years after we opened as CAMH, they created a program called Aboriginal Services. So that was a clinical program, and it really sought to bring cultural elements to, the patients that were accessing care. And so at that time, we employed the first elder at any hospital in Canada. That was Chipinison, Elder Vern Harper Bunn, who's now passed on. And there was a team for social workers. And this was really important, I think, for a hospital to make this investment and for the manager at the time to seek out funding to really, start thinking through how do we create culturally safe care in a hospital setting for our people. And just over a decade later, I joined CAMH, and it was a real opportunity to start thinking through some of the system opportunities. Initially, I worked in our human resources department, and then I was invited to join the Provincial System Support Program and as a manager of Aboriginal community engagement. And this was important because Ontario had just launched the mental health and addiction strategies, Open Mind, Healthy Minds, and they had prioritized Aboriginal and Francophone populations as priority populations. So the Provincial System Support Program at CAMH provided a lot of backbone support to then the Ministry of Health in implementing the strategy. And we had become really involved in these service collaboratives that were being organized across the province. And it was interesting because at that time, as these service collaboratives were being formed, they needed a lot of support in terms of engaging with Indigenous service providers. And so we started to build a team to help with that engagement. But as we were doing our work and in working across the province, we were starting to learn a lot and connect in with a lot of First Nation communities and really starting to see what the silos were and, quite frankly, the poor relationships that were existing between mainstream services and some of the Indigenous service providers. And so we were tasked with bringing these collaboratives together. And it also gave us a real opportunity to really start talking with our communities about what the gaps were, what their training needs were, because those were areas that I felt that we could be able to respond to. And so over the years, as we continued on with our engagement, we embarked on a bit of a journey to engage with not only those working in First Nations, Inuit and Métis communities across the province, but also those within our hospital, because I felt that we needed to learn as CAMH what our role was in terms of being a provincial service provider, and also what our role wasn't. There's this whole piece about staying in our lane. And so that was really important, and we ended up formulating a strategy called Guiding Directions. And it was a plan to strengthen our partnerships and practices with First Nations, Inuit and Métis. And that strategy was in place from 2015 to 2020. And, it was over those years that we started realizing that we needed to change some of the terminology. We needed to let go of these terms Aboriginal. And I was not in favor of having, quote, Indigenous services at CAMH, but I didn't know what to do about it, actually. I was not in favor of these pan-Indigenous kind of pathways that I felt weren't really rooted and grounded in our culture and within our life experience. And I really believe in distinction-based services. I think that the diversity amongst First Nations, Inuit and Métis is really important to understand and to put purposeful effort into providing services in a way that our people need to be able to receive them and in a way that they inform the development of these services. And very much to my surprise, and very naturally, the spiritual name Shkaabe Makwa emerged through me. And I was so surprised that we were going to have an Anishinaabe name for our program. And I struggled with that a bit. And I reflected on the fact that we were on Mississauga territory, because I don't come from that territory. I come from Treaty 3. I come from northwestern Ontario. But the way that I really came to understand Shkaabe Makwa is that Shkaabe comes from that word Shkaabewis, which is helper, and Makwa meaning bear. So it meant spirit bear helper. And this is the bear that is in the spirit world. It's not the bear that's in the bush. And I know that as a team, we had been using a graphic that Leo Yerksa from Couchiching First Nation, he's now passed on, had designed for us. And it was a bear. And we had used that as kind of a logo to represent some of our work. So whether we were organizing an event, we always had that bear on there. And it would signal either to our colleagues or our communities that our program, at that time it was called Aboriginal Engagement and Outreach, that we were a part of these services or this research project, or this initiative. And why we had that bear was because whether it was First Nation staff, whether it was Métis staff, or whether it was Inuit staff, we all felt a connection to the bear. And for me, being an Anishinaabe person, I always felt that the bear was very strong medicine because of those teachings. And I've often dreamed about bears, that bears have brought me things, they've showed me things, they've given me teachings, they've built me lodges. And so I brought that name forward to my team. We sat in circle in our ceremony room, and I smoked my pipe with them. I'm a pipe carrier as well. And we sat in circle for hours, and we went around and around, and we each shared our thoughts until we really felt comfortable and confident that Shkaabe Makwa, that's who we are, that's our helper. We're going to feast Shkaabe Makwa, and we're going to begin to walk forward with this program at CAMH. And so Shkaabe Makwa, as I was sharing, has not only a lot of work around our strategic initiatives at our hospital. We also have patient care, where we have clinical services that incorporate traditional healing as well. And we have a number of staff that support First Nations, Inuit and Métis people when they end up being admitted to our inpatient services. And sometimes people are coming into our hospital through our emergency department. And so just like primary care hospitals have an emergency department for those with injuries or who need primary care in an emergency state, we also have an emergency department. So if people are experiencing different types of mental health issues, whether they feel suicidal, whether they're losing touch with reality, whether they need medical withdrawal or addiction medicine, we have an emergency department, and the ability to be able to deploy one of our social workers to go to the emergency department and help our people when they're there. We also are involved in many system initiatives across the province. We lead a provincial workforce development initiative, and many times we're convening these curriculum circles with our knowledge keepers and with practitioners in our communities. So I really see the work that we're doing as very collaborative work and very responsive work in terms of addressing some of the, not only the needs of our workforce, but the needs of our caregivers and community members as well. We also focus a lot on research, and whether these are research projects that we are leading ourselves, we're currently working with a few First Nation communities on a CIHR-funded project called the First Nations Wellness Initiative. And we've had a different iteration of this project for over a decade and worked with a number of different First Nations on developing these strategies where we convene a community advisory circle and be able to co-develop surveys or different types of research tools. And, one of the amazing aspects of these research projects is that they build capacity within First Nation communities, because we hire staff that live within the communities, and many of them get access to really great research training and just the opportunity to be on the ground, but also be connected with really important research that we're able to do within the system.
So that is a lot of areas that Shkaabe Makwa is involved with. I think for our listeners then, how is this impacting First Nations people looking for help with their mental health?
In terms of some of the ways that we're able to, provide support, I would say that it would be not only, for those that need to come into the hospital in order to receive care. And we think about the fact that we're located in Toronto. So many of our patients are coming from the GTA, the Greater Toronto Area, but we do have a provincial scope. And so many times, we're having people come in from other parts of Ontario to access some of our services. And an example of that would be our youth inpatient unit. We have a unit that is designed for youth from 14 to 18 years old. At times, it's able to take on patients up to 21 years old, and the team provides care to those with concurrent disorders. And so that means that a person has a substance use issue along with a mental health issue. And so that is the eligibility criteria for that service. And I know that we have had a number of First Nations youth be able to come into our unit. It's usually about a 6-week stay. And, the feedback that we get is that the families and the youth are quite pleased with the service, and that the families are in touch with the care team throughout the time that their youth is in care with us. And then when they return to community, that they often do well. And we also follow through with connecting them with either outpatient services that we're able to provide or those within the home community as well. And so that would be one example. I'm thinking of some of our inpatient services. But I also just think about the pathway that First Nations people have, for someone coming into our emergency department and needing support. And whether they come in themselves or whether a family member brings them in or one of the service providers within the Toronto area that they might be working with, or sometimes the police, bring in our people as well. And, there they are able to have an assessment and then get routed to the appropriate services that they need. And if medication might be seen as something that would be helpful for them, then they're able to see a psychiatrist for that type of an assessment. And they're also able to be referred to Shkaabe Makwa as well. And so whether someone comes in through the inpatient services or if they want to access some of our outpatient services, so Shkaabe Makwa has a team of therapists. We also have a cultural care practitioner. And these cultural care practitioners provide cultural care within our hospital. And we also have a sweat lodge that we have on site. And we also have a teepee as well. And a specific area that is dedicated ceremony grounds that where we also grow medicines on our campus. And because we have such an understanding that in order for our people to heal, that there needs to be an element of spiritual safety and psychological safety and cultural safety, we know that we have to be able to provide these supports for our folks. And so I think that the more that we come to understand how it is that we really need to situate these types of support services within mainstream settings, and people have asked me, do we need to do this? Or should hospitals have these types of services? And years ago, I actually had one of the service provider leaders say to me, CAMH really shouldn't be doing these types of services. You should really leave the service delivery up to us. And it was about funding. And what's interesting is CAMH actually hasn't received, even to this date, any specific funding for our clinical services that is designed for Indigenous services specifically. So our core services do come out of our core funding, our core hospital services. But I remember at the time really hearing what this Indigenous leader was saying. And I said, well, at the end of the day, our people end up in hospital and we have to help them here too. And I think he heard me in a very different way because I wasn't being defensive, and I wasn't even saying that we're not applying for the same funding. All I'm saying is that we're here because our people are here, and we know that, and we know that they're struggling. And we know that many of our folks that come to CAMH, have had really difficult life experiences. They've had a hard time accessing services and have often fallen through the cracks, and that's why they end up in hospital. And so I think it's a really good opportunity for us to really sit with them and start to plan with them the care pathway that will lead them to wellness.
Rennie Linklater's book, Decolonizing Trauma Work, Indigenous Stories and Strategies, was a result of her PhD research. As Rennie became aware of the multi-generational effects of colonization, from residential schools, child welfare, and other injustices imposed upon Indigenous communities, she considered how the lingering trauma and lack of healing from these harms impacts the workplace in terms of our relationships and our ability to work together. She centered her PhD research around trauma and the workplace. On the advice of an elder, she ensured that her thesis would be solutions-oriented. Rennie spoke with 10 Indigenous healthcare practitioners about Indigenous notions of wellness and holistic health, and Indigenous approaches to helping people through trauma, depression, and experiences of parallel and multiple realities. They also explored critiques and limitations of psychiatry and psychiatric diagnoses. The resulting research and book offer practical methods to help individuals and communities who have experienced trauma. Her findings continue to inform Dr. Rennie Linklater's approach to her work today.
I guess this is related to what you were mentioning about the work Shkaabe Makwa is doing in decolonizing healthcare. Can you share about that? Does that work extend beyond the hospital, beyond CAMH, into the larger health system?
Yes, thanks so much for that question. When I think about decolonizing healthcare and this notion that actually that's exactly what we're doing at CAMH. And it's interesting because I think about the ways that we do our work and, the fact that when Shkaabe Makwa was coming forward as a name for our program, that we sat in circle and we smoked pipe together. And when I think about those months before we came forward with this idea to have the sweat lodge at CAMH, we knew that we needed to have a ceremony. We knew that we needed to ask for permission, ask for permission from the Creator, from our ancestors, from our helpers, and for those that have been on the land that our hospital now sits. And what's interesting about our hospital site is that what we've learned is that it was the traditional territory and the council grounds of the Mississaugas of the Credit. And we found in the archives that it was noted that the Provincial Asylum of Lunatics now sits on the grounds where the Mississaugas would hold their council meetings and come and camp. And I think about that. And so I often reflect with our senior leadership, with our executive leadership and our board of trustees on what was taking place on our land before the hospital was here. And so when we were doing those ceremonies for the sweat lodge and doing our offerings, we also became aware that there were a number of people that had been harmed at our hospital, many people from many different nations. And so part of our work were to do offerings and to help those spirits move on to the spirit world because some of them were stuck. And it's interesting because now, and I think it's because I've been at the hospital for, the amount of years that I have, I've become a lot more confident in talking about how we do our work. And I've made it very clear to our leadership that we're able to do this work not because we have PhDs and masters within the staff collective at Shkaabe Makwa. We're able to do this work because we're culturally grounded. We know our teachings, we know our orientation, and we know how to convene our people to come together to really offer services and supports in a way that is very appropriate and culturally responsive. And so I think about that. I think about our work is very spiritual, and it has an integrity that I feel is really important that we continue to honor.
That's interesting. I wanted to ask you what kind of suggestions you might give to other institutions who are looking to take this decolonizing healthcare approach. You mentioned that point about being culturally grounded, and that's often such an important element, is having the people working within the organization who are bringing that cultural grounding into their work. So,
yeah, we're in a really interesting time. when we think about our employees and who we're recruiting into some of these positions. When I was in my 20s and learning a lot of things culturally, but also in university at the same time, my aunts and uncles were constantly talking to me about be careful about the book learning, be careful about the book learning. And that has really stayed with me. You know, when I think about it today, and I think about my journey, which I had gone through, which was really, you know, a cultural pathway grounded in ceremony because of my own illness and because of my need to access our kind of Anishinaabe health system in order to become well. I think about those that have grown up kind of distant and haven't really had the opportunity to return to culture and to even within themselves connect themselves holistically. And when I refer to that, I think about how we need to come together spiritually with our heart, with our mind, and with our body. And part of, you know, a traumatic response is to be fragmented in the way that we walk. And we do that because it's safe. You know, and I know that in times when I had experienced trauma, like my mind was completely outside of my head because it couldn't be in my body. My body wasn't safe because of what it was remembering in those times. And so I think about these days where we have a lot of people that are in this place of book learning, and sometimes these people end up in positions where they're in leadership. Sometimes they're writing curriculum for education sectors or medical education, yet they don't fully have all the knowledge to be able to do all of that work in a way that's really aligned with our teachings. And I think it's challenging because I also think that these opportunities to develop ourselves and to evolve our beings are not easy to come by. You know, it's like we have to be guided, we have to be connected with our elders.
Well, and these opportunities are kind of reduced now. Every year I'm getting a sense there's fewer opportunities because many of our elders are passing away, and then hopefully finding the teachers who receive those teachings to carry them on. I have a sense it's very much in flux right now.
Yes, agreed. And that concerns me that it's in flux because I think that we need to figure out how to broaden these opportunities. And I think that, you know, this is one of the ways that we've been able to do this in the hospital. Is I think about those people that didn't have the opportunities that I had to go to ceremony, to go to a shake tent, to have their family surround them, to walk them on this pathway. And so if we can provide some of that in a hospital setting, and I think about that in terms of decolonizing healthcare, and I think about the really important work that other hospitals across Ontario are doing. They're starting to understand that we need Indigenous patient navigators in our emergency rooms to be able to sit with our people, to sit with our families as they're coming in, to offer them traditional medicines, to argue with our healthcare providers and systems to be able to explain why we need medicines in ICU, why we need more than 2 family members in a room when, you know, we have someone going through a life crisis. There's been great strides, I would say, within our hospitals in Ontario. But I also think about, it was only back in 2016, so 8 years ago, that CAMH stepped forward and we opened the first sweat lodge on the grounds of a hospital in Ontario. Now there's a few more, which is great. But that comes about because we have leadership. And not only Indigenous leadership, we have executive leadership at hospitals that believe in these healing methodologies and have opened up the space for us to step in as First Nations leaders to be able to lead these processes.
That's good. So I guess that's important. By offering these services, when a patient comes to CAMH, then that gives them a doorway to connect with the Anishinaabe health system.
Well, I think we have the opportunity here is not only connecting with those that really need supports, but also helping them connect with other services. And so in Toronto, we can connect people with Anishinaabe Health, with a doge, which is a new primary care team within the city. We can connect them with shelters, whether they're Nami-Res or Undayan, or Native Child and Family Services for other types of services as well. And so I think that when we think about our service system. It really is about relationships, and it's so important that those of us that are working within the system are connected with each other. And so, we routinely work in partnership with many of the other Indigenous service providers in Toronto and across the province. And some of our work, we've got some really interesting initiatives coming up that started with a research focus. And one of them is a new alcohol withdrawal management program that is going to be offered virtually. And we're working with 3 service providers right across the province, one in northwestern Ontario, one in Manitoulin Island, and one in Toronto. And we'll be co-designing this new virtual alcohol withdrawal management service where we have people, even with lived experience, helping within some of these initiatives as well.
So in closing, is there anything else you wanted to share about your work? Or just in general to add on to this, our conversation?
I think something that we all need to think about is the importance of really tending to ourselves, really tending to our own needs and our own spirit, and putting things in place in our lives, whether they're tools, whether they're medicines, whether they're people, whether they're certain community aspects that help us be connected and help us be all that we can be. And when I think about that opportunity of what the Creator wanted us to be in terms of our self-actualization, because when the Creator brought us into this world, there was a plan, there's a pathway, and we have a purpose. And I think, this journey to explore what our purpose is and be able to contribute to our communities in whatever way that is a really heartfelt place to be within our world.
Miigwech, Rennie Linklater, for sharing your wisdom with us in the podcast. Miigwech.
Thank you so much, Lisa.
Miigwech to Rennie Linklater for taking part in the podcast, and to the Anishinaabe Nation Health Department for supporting this episode. To learn more about Shkaabe Makwa and Rennie Linklater's work, find the links in the podcast description. We've also included a link to another book that Rennie Linklater edited called Connected in Creation, a collection of lived experience through cultural expression. In this book, members of the staff collective at CAMH share their personal perspectives related to mental health and substance abuse issues. It is their hope that these stories will inspire others to support those with lived experiences to find pathways to share their voices and inform system improvements and culturally relevant services to advance the healing and wellness of Indigenous peoples. This episode includes the tracks Brothers by Wolf Saga and Chippewa Travelers, and Falling Forward by Justin Delorme, licensed by Nagamo Publishing. Miigwech for listening to B'madzache Ganonindwa. Until next time, Bama Pi.